Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm Dr. Aladdin Segar. Today's episode covers 3 important papers spanning sleep medicine, extracorporeal support, and critical hypothermia management. We start with a major prospective cohort from the European Respiratory Journal looking at long-term cardiovascular risk in obstructive sleep apnea and the real-world impact of positive airway pressure therapy over 14 years. Then, we move to a large, multi-center randomized trial in JAMA evaluating whether Levosimendan actually helps wean patients from VA ECMO, a question that's been hanging over cardiogenic shock care for years. And finally, we close with a JAMA Insights review on extracorporeal life support for accidental hypothermia, a concise, high-yield synthesis with direct bedside implications. As always, this podcast is for educational purposes. Full citations are available in the description. Let's get started. Published in the European Respiratory Journal, this large prospective cohort study from the Spanish Sleep Network follows more than 5,358 adults with obstructive sleep apnea for a median of 14 years, an extremely long observation window in sleep research. The central question is clinically simple but historically unresolved. Does positive airway pressure therapy reduce the risk of non-fatal major cardiovascular events and death? The controversy exists because randomized trials in non-sleepy patients with OSA have repeatedly failed to demonstrate cardiovascular benefit. Yet most of these trials applied PAP in tightly selected populations, often with suboptimal adherence. This study takes the opposite approach, a real-world, longitudinal, pragmatic design following patients diagnosed between 2002 and 2004 and observing outcomes through 2018. The cohort's mean age was 55 years, mean BMI of 32, and the average AHI was 35 events per hour, placing most into the moderate-severe OSA range. Roughly 84% met criteria for positive airway pressure, but only 37% actually remained adherent over time. That low adherence is unfortunately realistic. During follow-up, 754 patients experienced a non-fatal major cardiovascular event, and 858 deaths occurred, meaning nearly 30% encountered a major adverse outcome. Baseline predictors of non-fatal major cardiovascular event or death were unsurprising but clinically useful. Age over 60, prior ischemic cardiomyopathy or cerebrovascular disease, AHI more than 30, non-HDL more than or equal to 200 milligrams per deciliter, COPD, and atrial fibrillation. These form the backbone of the risk estimator the authors developed. The key result is straightforward. Positive airway pressure adherence was associated with a substantial reduction in long-term risk, with an odds ratio of 0.46. In absolute terms, the median risk reduction was 16%. What makes this study persuasive isn't the effect size, it's the consistency. Even after target trial emulation using inverse probability weighting, adjusting for baseline differences, and stratifying by primary versus secondary prevention, the protective association persisted. Importantly, the event curves separate early and stay separated through year 14. Editorially, this study lands in the gray space between ideal evidence and real-world pragmatism. Is it a randomized trial? No. But a 14-year randomized positive airway pressure trial is impossible. This is likely the best approximation we will ever get of long-term cardiometabolic risk trajectories in OSA. The model's area under the receiver operating characteristic of 0.75 is respectable, and the Breyer score of 0.17 reflects solid calibration. The bedside implications are clear. For moderate-severe OSA, especially in patients with cardiometabolic risk factors, positive airway pressure should be framed not just as a sleep therapy, but as a cardiovascular risk-modifying therapy. Clinicians should emphasize adherence early, preferably within the first 3 years, as treatment behavior in that window largely predicted long-term classification. The calculator derived from this dataset may actually help conversations with skeptical or minimally symptomatic patients, the exact population where positive airway pressure adherence tends to break down. This paper quietly shifts the narrative. In appropriately selected patients, there is now durable evidence that positive airway pressure protects the cardiovasculature over time. Published online just a few days back in JAMA, the LEVOECMO trial finally answers a question that's hovered over cardiogenic shock management for over a decade. Does Levosimendan facilitate weaning from veno-arterial ECMO? This was a randomized, double-blind, placebo-controlled, multi-center trial conducted across 11 ICUs in France, enrolling 205 patients with severe but potentially reversible cardiogenic shock. Patients had initiated VA ECMO within the prior 48 hours and were randomized to receive either Levosimendan, titrated from 0.15 to 0.20 micrograms per kilogram per minute, or a visually matched placebo. The population was representative of modern ECMO practice, median age 58 years, 73% male, with etiologies including postcardiotomy, acute myocardial infarction, and myocarditis. The baseline SOFA scores averaged around 12, indicating profound multi-organ failure. The primary endpoint was time to successful ECMO weaning within 30 days, with the key nuance that success required the patient to remain alive without ECMO, without need for another mechanical support device, and without heart transplant for 30 days after decannulation. This is a stricter definition than many registry studies use, and appropriately so. The authors wanted a clean assessment of true myocardial recovery. The outcome was unequivocally negative. Successful weaning occurred in 69 out of 101 patients, or 68.3% with Levosimendan, versus 71 out of 104, or 68.3% with placebo, yielding a risk difference of 0.0%. Secondary outcomes mirrored the primary. ECMO duration, mechanical ventilation-free days, ICU length of stay, and 60-day mortality all showed no significant differences. The only meaningful safety signal was a higher rate of ventricular arrhythmias in the Levosimendan group, 17.8% versus 8.7%, with an absolute risk difference of 9.2%. The editorial accompanying the trial highlights an important methodological point. Although the trial was powered assuming a 50% baseline weaning rate, the actual baseline success rate was closer to 68%, meaning the trial may have been underpowered for smaller effects. But even so, the absence of any directional signal across primary or secondary outcomes is compelling. From a clinical standpoint, this trial likely brings closure to the long-standing belief, supported mostly by retrospective and observational data, that Levosimendan might facilitate myocardial recovery during ECMO. In countries where the drug is approved, its use for ECMO weaning should now decrease sharply. More importantly, LEVOECMO reinforces a broader lesson in critical care therapeutics. Physiologic appeal does not guarantee clinical benefit. Levosimendan increases calcium sensitivity, improves output, reduces wedge pressure, and produces attractive hemodynamics. Yet, in the biologically chaotic environment of cardiogenic shock, these effects do not necessarily translate into improved survival or liberation from mechanical support. In summary, LEVOECMO delivers a clean, well-executed answer to a long-debated question. Levosimendan does not facilitate ECMO weaning, and it increases arrhythmia risk. Clinicians should adjust practice accordingly. Published in JAMA, this clinical review synthesizes the evaluation and management of accidental hypothermia, with particular focus on extracorporeal life support for rewarming. Although not an original trial, it provides a high-yield, evidence-anchored framework that is immediately relevant to emergency, critical care, and ECMO teams. Accidental hypothermia is defined as a core temperature below 35 degrees Celsius, classified as mild when 35 and 32 degrees Celsius, moderate between 32 and 28 degrees Celsius, or severe when less than 28 degrees Celsius. The review emphasizes a key practical point. Accurate temperature measurement is foundational, and esophageal temperature remains the gold standard, particularly during dynamic rewarming. Peripheral readings, especially infrared ear thermometers, are unreliable and should not guide treatment decisions. Clinically, severe hypothermia carries a dramatically increased risk of cardiac arrest due to myocardial irritability, low perfusion, and susceptibility to arrhythmias. Rescue collapse, a phenomenon where even repositioning a patient triggers arrest, is associated with double the mortality risk. Recognizing this risk is essential during extrication and transport. The review delineates clear criteria for extracorporeal life support consideration. Young, otherwise healthy patients with temperatures less than 28 degrees Celsius and older patients with less than 30 degrees Celsius should be transported to an ECMO-capable center whenever feasible. Importantly, there are no absolute contraindications, aside from obvious signs of irreversible death or uncontrolled bleeding. The survival data are striking. In a retrospective multi-center cohort of 65 patients older than 70 years, with unwitnessed arrest or asystole, arguably the worst-case scenario, 37% survived to discharge, and 83% of survivors had favorable neurological outcomes. Broader analyses show that among 221 unwitnessed hypothermic arrests, 27.1% survived, and 83.3% of survivors had good neurologic recovery. These numbers far exceed typical ECPR outcomes in normothermic cardiac arrest. The review also clarifies an important physiologic misconception. End-tidal CO2 is not reliable in hypothermia, given the increased solubility of CO2 in cold blood and reduced metabolic production. Very low end-tidal CO2 values do not predict futility, a critical distinction from standard cardiac arrest algorithms. Prognostication tools like the ICE, HOPE, and HELP scores can aid decision-making, though they should supplement rather than replace clinical judgment. The HOPE score remains the most commonly used and is externally validated. What stands out editorially is the author's emphasis on the reversibility of hypothermic arrest. In contrast to cardiogenic or arrhythmic causes, hypothermia provides a unique window where prolonged arrest, even beyond 100 minutes of CPR, can still result in excellent neurological outcomes if ECLS rewarming is applied. This reframes hypothermic arrest not as a terminal condition, but as a treatable physiologic state. For clinicians, the message is straightforward. If a hypothermic patient is in cardiac arrest and ECLS is available, proceed. The survival odds justify aggressive management, and traditional futility markers do not apply. That brings us to the end of this week's episode of This Week in Pulmonary and Critical Care Medicine. Thanks for spending these minutes with me. Today's papers pushed us in 3 different but important directions: long-term cardiovascular risk in sleep apnea, a definitive randomized trial in cardiogenic shock, and a practical, high-yield review on managing hypothermic cardiac arrest. Each one reshapes the way we think about risk, recovery, and what benefit actually looks like at the bedside. If you found this episode helpful, consider sharing it with a colleague. These discussions work best when they're part of a larger, ongoing conversation in our field. As always, you'll find the citations in the description below. I'll be back next week with more studies that matter to your practice. Until then, stay curious, stay critical, and take care.